of you were able to hear the wonderful feedback uh, the dean of our medical school provided regarding his recent trip this past fall to Thailand.
Oh,
And
we don't hear that, but and that is great. Can you share a little bit with us?
I had him and his wife over to our house to celebrate him going from the interim dean to the dean. And we spent a portion of the evening talking about the wonderful relationship that we have and how much we in the cardiovascular program have really enjoyed working with you and each of the members and the various sites, and how fulfilling it has been. And he shared his excitement and his enthusiasm and shared similar feelings about his visit last fall. So I just wanted to share that with you.
That is
And
excellent.
and today we have a wonderful case and perspective on complex PCI by our interventional fellow, Dr. Timothy. And we hope that you all find it interesting, and it'll serve as a great focus for some discussion. So thank you for giving us the opportunity to present this afternoon to you all.
Thank you. The
Excuse me, this
same.
morning. It's our afternoon, it's your morning.
Yeah, thank you for the same feeling. The feeling is mutual, and we have a great interaction with your dean and the wife last fall as well. So we great. We're glad to hear the similar feedback from your end. And without further ado, I think Tim can start.
Good. And again, thank you guys for having us. I'm going to share a case today, and it'll be a little bit more didactic than in the past. But I think if there's any questions, concerns, please stop me and interrupt, and um, we can make this as interactive as possible. I'm going to share a case and then hold off of that in regards to performing left main bifurcation interventions in
and what is the most evidence-based mechanisms of interventions as we know today. So we'll start with a case. This is a 79-year-old gentleman who presented to an emergency room with several hours of chest pain that was crescendo in nature. He carried with him a history of known coronary artery disease that was approximately a 40 to 50% distal left main lesion and 70% osteocircumflex, which was opted to be medically managed. That was discovered in the setting of an angiogram that was performed for severe aortic stenosis. So here in the States, these folks will typically have a coronary anatomic evaluation prior to proceeding with the valve intervention, whether percutaneous or surgical. In this case, it was opted to be medically managed, and he proceeded with undergoing a TAVR with a 29 millimeter Evolut Pro Plus, which itself was complicated by a heart block, had a pacemaker placed, and you can see his comorbidities were hypertension and hyperlipidemia. At the time of admission, he was on aspirin 81 milligrams, apixaban, metoprolol, and simvastatin. His labs on presentation, creatinine was normal, as was his hemoglobin and platelets, and he had a high sensitivity troponin that initially was about 300 and increased up to about 3,000, consistent with an NSTEMI. He was admitted to our cardiology ward where he was given aspirin. He was started on a heparin drip in addition to receiving a statin. Echo was done shortly after his admission that showed normal left ventricular size and function. The bioprosthesis was functioning appropriately. His mean gradient was 11, which is effectively what you would expect with this type of valve at a normal cardiac output. It had no other significant valvular disease. So overall, pretty reassuring. Had no significant wall motion either. His ECG, you can see here, a lot of slides, so I won't go in too much depth here, but no marked ischemic changes. You can see the repolarization expected with the bundle and the lateral leads. No significant ST elevation. or depressions, and no evidence of prior infarct outside of perhaps the high lateral. So the first challenge to highlight is engaging the coronaries through this core valve. And so I gave you the history of this gentleman had undergone a TAVR approximately a year prior. Perhaps I'll pause and query the group experiences or challenges and or tips when you go to engage coronaries through this core valve, if you guys have any experience with that. Maybe I'll ask you guys, in your practice, do you guys have core valves available or care for patients who have had core valves implanted?
Hello. Anyone want to answer Dr. Timothy's question? I have seen a number of the doctors joining. Anyone wants to answer him?
So just to repeat the question, are you all encountering patients who have been treated with the Medtronic core valve?
มีใครเคยเจอคนไข้ใช้ Medtronic valve ไหมคะ
Dr. Wanapaka, at RPH, we have not found this patient like this.
Okay.
So no one has encountered it, Wanapam?
One moment, please. I am trying to ask Dr. Damlat offline because he is in the bad signal area. One moment, please.
Thank you.
So this is a transcatheter valve that is fairly commonly used here in the States. It makes up a large minority of the valves that are implanted in people who undergo percutaneous valve intervention here. And it's a supraannular valve. And so you can see here approximately at the level of the annulus, and then it extends up into the ascending aorta beyond the level of the sinotubular junction in some instances. And so it can be incredibly challenging to re-engage the coronaries because you're the necessary challenge is that you are bringing your catheter in through one of these diamond-shaped cells and then protruding back into the coronary ostium prior to performing your injections. And so it can be in its own, an incredible challenge to engage the coronaries through these valves. And so having some experiences, pre-shaped catheters, a JR, is almost always necessary for the right, if not a longer nosed catheter like an AR mod. And then when it comes to engaging the left coronary, and here's a nice example. You can see the catheter protruding through the stent struts, through the cells into the ostium of the right coronary. So it can be quite a challenging situation. When you go to engage the left, almost exclusively you have to use a JL catheter, and often you find more success in using a intentionally short JL catheter, really bringing it down to the level of the cusps within that stent, and then gently advancing it through one of these struts. And it's a little bit of luck in finding the right cell to be able to engage the coronaries. So this is something that we do encounter with some frequency here, but it it's quite a challenge, especially when you start talking about performing interventions through these frames.
It's also used a fair amount in Europe, Germany, France, the Netherlands. So in some patients who are traveling to Thailand, you will find that their AS will have been treated with the core valve.
Certainly something likely to be encountered in the future. As far as this gentleman's coronary anatomy, so he came in with an end stem. He was known to have distal left main stenosis, and here you can see likely progression of the distal left main with involvement of the ostial circumflex there, with a really pretty severe near critical stenosis, and also involving the proximal portion of the LAD as well. The right coronary system had some moderate stenosis as well, but nothing that appeared to be the culprit. So we went through our progression. Now that we have we're overcome the challenge of engaging the coronary and getting some nice angiographic images here, we were able to kind of further discern what we thought was going to be the etiology of his end stemming, and that turned out to be a distal left main bifurcation disease. We're going to talk a bit about this today, go through some of the evidence. How do we tackle this in the current era with everything we know? So to highlight, it's bad, and it's bad in a number of ways, but mostly prognostically. Distal left main stenosis carries with it a more serious prognosis than other types of lesions, and it's commonly identified. So up to 5% of angiograms have significant left main disease when you look at even like epidemiologic populations, and most of these involve the distal bifurcation, up to 80% of lesions. So it's something that carries significant prognostic implications. It's encountered in practice with some frequency, and it can be a challenge to interventionalists in managing these folks. I'm going to highlight just a little bit of the background data. And this is in part because this is an evolving role. It's largely historically been a surgical condition, but as we're seeing, more and more people who are of advanced age and non-surgical candidates, and some of the evolving data, this is the tide is shifting a little bit towards a little bit of equipoise and/or increasing frequency of PCI in these types of patients. And so, this is from the syntax left main cohort in 2014. It was published that showed that in people with a low or moderate syntax score, they tended to do reasonably well with PCI for left main. This is not specific to distal left main, but all left main. I'm gonna highlight 3 studies here, and they all generally show similar findings. And what that shows is a similar event rate of all-cause death, overall similar rates of composite MACE, and increased risk of repeat revascularization with PCI in these folks, and a trend towards increased risk of stroke with surgery. That's the trend that we saw in the syntax left main cohort. The Noble trial, which was another randomized clinical trial of PCI versus CABG in these patients, showed effectively the same thing. And then the most recent trial was the Excel trial, which showed, again, effectively the same thing. So overall, similar mortality, all-cause mortality, increased risk of repeat revascularization with PCI, slightly increased risk of stroke with bypass surgery. And so that's kind of the foundation of data, which has built the current recommendations. And I like this graph because it highlights the ESE and the AHA guidelines in one image, but it effectively says that, in low or intermediate syntax score, one can make a reasonable conclusion that either may be a revasc option. There are some considerations that may push you towards percutaneous intervention versus a bypass in a given individual. Examples: low EF, issues with adherence, diabetes or multivessel disease, high syntax score. Those are all considerations that would push you towards bypass surgery versus people who are advanced age, have high comorbid burden, reduced life expectancy, et cetera, or low syntax. One may consider PCI in those type of patient population. But that's the foundation for what is known about the topic today. So my the question that I really had when I built out this talk was how do we best perform left main bifurcation PCI in the current era, 2023? And how can we give our patients the best opportunity for a really quality long-term outcome and prognosis if they do undergo PCI in this setting? So we're going to go through, the steps that I would take and have outlined. One is the anatomic assessment. 2 is planning your upfront strategy. 3 is anticipating and performing a single stent intervention. And 4 is performing or deciding when to do a bifurcation intervention if one is needed in a bailout
So
situation.
Tim, let's go back to that slide, and it may be a good, so when we take a look at these, how we assess by anatomy, and then whether we perform a single stent or a dedicated, let's just go back to that angiogram momentarily and see who in the group would approach this with a single stent versus a bifurcation 2-stent approach.
Show you open that up to the group for Dr. Seguro's question. How would you guys best approach this distal left main patient who's coming in with an acute coronary syndrome presentation?
Any cardiologist want to comment according to what Dr. Timothy asked?
It's an unusually quiet group this morning.
Hi, I'm Dr. Sujina from Krungthep Hat Yai Hospital. Can you hear me well?
Yes.
Perfectly.
Okay, so I'm the interventionist. So the commentation from me would be, I think the lesion is through bifurcation, and the extent, the length of the lesion is quite is more than almost to 20 millimeters. So I would go for 2-stent technique for this bifurcation.
Great. Any other comments that might differ before we move to the next phase of the talk?
Hello, I'm Damraj speaking.
Good morning, sir.
Good morning. Good morning. I'm sorry that I'm quite have a problem to connect to this meeting. But anyway, this is a very difficult case because it is involve only the ostial circumflex, and also I can see calcification on the left main from the fluoroscopy, heavy calcification, and it's very difficult to treat this side branch only. So in my technique, I always use MAD strategy, MADS. And this is the case with should be focused on the number S. The number S means stent side branch first. So there are 2 techniques to do the stent side branch. First, to protect the left main and send the side branch only with the we call technique as outer crutch. Or second, do the double kissing crutch, stent side branch into left main, and then the rewiring. Do first kissing and stent left main and do second kissing. So there's only 2 ways. The worst one is culotte. So this is a very, very difficult to treat, and I try to avoid this ostial circumflex because it came with a nightmare later. As you know, there is one stent, but it's not theoretically. It's very good. We call capillary side guard. If you have capillary side guard, then it can protect the ostial left main and it flare on the at the ostial side. What do you think? You can show your strategy and treat a case like this.
Yeah, both of you provided great insights and points, and so we appreciate that.
will proceed through kind of how one can potentially should approach these lesions. Then we'll talk about what we did in this case. And the first, as everybody I think had done in one way or another, is to assess the anatomic complexity. And so someone had mentioned kind of the Medina classification, evaluating the side branch stenosis and the lesion length. And so, there are several anatomic risk assessment tools or scores. The Euroscore or Syntax or some. Interestingly, it was prognostic in the sense of the Syntax left main cohort. The higher the Syntax, the worse people did. However, it was not predictive in the Excel or the Noble trials. And so it's a little bit unclear how we best should use the Syntax score in the structure or setting of distal left main stenosis. The only dedicated, at least the only commonly used dedicated anatomic assessment is from the definition trial. And that's what's outlined below. And this was, again, a dedicated left main bifurcation anatomic assessment validation trial. And they broke it up into major and minor criteria. And the first is the side branch lesion greater than 10 millimeters with a stenosis greater than 70%. One would consider that a major criteria, and I'll talk about what they did in those folks. Or if you met sufficient minor criteria, including calcifications, as you guys pointed out, multiple lesions, unfavorable angles, etc., or thrombus-containing lesion, then you can consider those a higher risk lesion. And then our Medina classification as well, pointing out that this is an angiographic classification that was validated with quantitative coronary angiography, but that's kind of extrapolated into kind of visual interpretation of angiographic images, is very commonly used as well. The first step, or one of the first steps when you consider an anatomic assessment, is the bifurcation angle. And the reason that can be important is it can guide your strategy in part because of its prognostic implications. And so when we look at, we'll talk a little bit more in depth about the anatomic assessment of the bifurcation, but when you look at the bifurcation angle alone, the greater the bifurcation angle between your LAD and circumflex, and this is specific for left main disease, the higher the risk of side branch occlusion and repeat revascularization. So this is one of the main anatomic implications when you evaluate patients with distal left main. And it guides your strategy to some extent. So the wider the angle was associated with worse outcomes with culotte, mini crush, but not DK crush, to your point. So one may consider in someone with a wider bifurcation angle, DK crush strategy may be more favorable, at least in studies, is more favorable to a culotte strategy. And this is from the definition trial, and so they identified lesions as either complex versus simple, with those criteria that I kind of touched on briefly. And it's important because, again, it carries prognostic information. So a complex lesion, this is event-free survival. People with simple left main bifurcations were alive on average longer, or had less had a higher increase, or higher cumulative event-free survival than people with complex lesions when you apply this classification. And then interestingly, so this is from the definition trial, they broke it up into two arms. People with simple left main bifurcation, regardless of the strategy, whether it was a provisional or a two-stent up front, they had very similar event-free survival. Compared that with people classified as a complex left main bifurcation, those who had a dedicated two-stent strategy, if you met those criteria, tended to do better than folks who were randomized to a provisional strategy up front. So this is in part why an anatomic assessment of the lesion is a important place to start prognostically, and then as you start to plan your technique or planned intervention. So when you look at, this is one of many algorithms that are out there for left main bifurcation, these are critically important assessments, is the side branch angle greater than 70%, if it's complex lesion, length of the side branch stenosis, that may push you to a dedicated bifurcation strategy up front, specifically DK crush, versus taking a provisional approach. Well, maybe I'll pause there and see if anybody has any questions or comments about kind of this proposed strategy based on the data that we just briefly reviewed.
Any side want to comment on Dr. Timothy's question?
สวัสดีครับ I'm Dr. บุญสม from Bangkok หาดใหญ่ Hospital. Can you hear me? Hello.
Yes, sir.
Okay. I think this is the important things for decision about the left main PCI. And in this case, I think the angulation is limit for some strategy. And I think this in the same I use the two stent techniques for this left main bifurcation because the first when I see the left main bifurcation, this is a true bifurcation and the carina of the it has a turbulent flow more than 80%. It has the program is has the many step or difficult. In this case, Q-lock may be limitation when see the angle, but maybe or sometimes it can use in this case. And the simple technique, I think, is maybe useful just as the mini crush technique or tap technique, just as the back procedure proposed. Use the 7 frame for the guiding and use the true cuts or modified cuts at the left main but it should be optimized by IBUS or OCT confirm imaging. I think this is the important point. Thank you.
Your point, regardless of your bifurcation or provisional strategy, I think, yeah, these are the folks who imaging is really going to be critical in optimizing their outcomes. So absolutely, 100% agree.
อาจารย์นำรัตน์ any comment from you as well for this? Thank you, Dr. บุญสมนะคะ อาจารย์นำรัตน์มีคอมเมนต์ไหมคะ I cannot hear you ค่ะอาจารย์ อาจารย์ your microphone is mute ค่ะ
Hello, can you hear me?
Yes, now we can hear you ค่ะ
Okay. Have you ever used X position S stentis?
SKS, you said?
X position S stentis.
Oh,
It is a self-expandable stent with the just disconnect the strap to open to the side branch. We are among the highest volume center to use this X position stent. It is self-expandable. You can deploy from circumflex to left main, and then just use small balloon to disconnect the connecting strap to open the flow to the left main. unfortunately, that stent is out of market for a while because the president of the company passed away, and the shareholder cannot negotiate for the future of the company. But I have this experience. You can see from the literature, exposition stentis for this type of lesion, it is dedicated bifurcation stent. And it make life more easy, more those decay crush or culot or whatever.
I don't know that we have any dedicated bifurcation stents on the market at this point.
No.
Yeah. So I was going to walk through, the single stent provisional strategy in this case, and in part, this is the most common strategy that's employed in the States. We do, I think, as compared to parts of Europe and Asia, we do less dedicated bifurcation stenting by and large, and this is the predominant strategy here. And approximately 75% of distal left mains employ this strategy, most commonly a crossover from the mother to the daughter vessel. And I have a lot of interest in the data behind why we do all of the small steps within a certain technique, and that's what we're going to go through here in the next couple of slides. And so the typical progression of this strategy would be to wire your main vessel plus or minus your side branch, talk about stent, talk about proximal optimization technique, and then reaccessing your side branch and how to risk stratify into a failed provisional. And the first step is, when do you need to wire your side branch in a provisional case? And there are many risk factors for side branch loss, but the strongest amongst, when you look at several different studies, is reduced TIMI flow prior to intervention in your side branch, and then the ratio of the mother vessel to the side branch, with the higher ratio being worse. There are other ones, including the plaque morphology and the location, if it's contralateral to your side branch versus ipsilateral or involving the carina. Acute coronary syndrome is a risk factor, but you'll see at the very bottom that actually left main lesions have a favorable prognosis for side branch loss. And so more often than not, you're not losing your side branch when you talk about a left main, the LAD, or circumflex into main. That risk is fairly low across the board. And there's really three mechanisms of side branch loss, and one is thrombus displacement, thrombus propagation. The second is plaque disruption or plaque protrusion into your side branch. And then the third, and you'll see at the bottom, which is an example here, is carinal shift. And so you can see this is kind of your long view or your L view on an IVUS pullback with this, they call it the spiky tip carina, where the carina protrudes somewhat out larger or longer than expected into your main branch. And after stenting, you can see that carina collapses down, occluding the side branch. And so you can get carinal shift as a mechanism of side branch loss as well. But those are the three major contributing mechanisms for side branch loss. And, there's always a question is why do you wire a side branch? If a vessel is going to promptly be occluded, does that actually increase your success of reaccessing that side branch once it's lost? And it turns out there's a paucity of data. There's not much data, but this is from the DK Crush dedicated trial, where they identified that if you had a side branch wire that lost flow, a jailed side branch wire increases the probability of recovering flow in that vessel by about 25%, or about a 50% increased probability of recovering that side branch. And this is important. Side branch loss is prognostically important. This is in all comers with side branch loss. This is not even when we're talking about distal left main, which carries even stronger prognostic importance. So, it is and can be important to salvage your side branches, and a marker wire is helpful in that. So when we talk about employing our provisional strategy, we're appropriately sizing our stent according to the distal reference, taking care not to oversize, which is going to increase your probability of this carinal shift in side branch loss. And so we place our stent from the main vessel into the daughter vessel, sized according to the distal reference. And then there's really good data, and I'll show some of this for proximal optimization technique. So when you can see in our figure on the top left here, when we appropriately size our stent according to the distal reference, there will be expected malapposition within the proximal main vessel. And in order to correct that, we use a 1-to-1 size balloon according to the proximal vessel. And then the importance of POT is really in meticulously positioning the stent within figure there. It's the meticulous position within the main vessel. And you'll see here, if you're too deep, you can have that carinal shift. If you're too proximal, you're not going to expand your stent within the side branch, and you can cause issues for yourself. And the data here is I think really telling that proximal optimization technique, when performed appropriately, increases your expansion, your apposition, increases the size of the side branch cells, increases your likelihood of side branch wiring, minimizes the chance of going around your stent or abluminal wiring, and then it restores stent deformation that we'll talk about here in a second when we talk about kissing strategies. So I think that the data is strongly in favor of optimizing your proximal stent, and the clinical outcomes are notable: decreased risk of target lesion failure, target vessel MI, and stent thrombosis when you talk about optimizing your proximal stent. So in this instance, I'll get back to our case in a second. We did employ a provisional strategy, and we stent from the circumflex into the left main. And then, to me, the big question is, then what do you do? So do you stop and say you're done? We optimized our proximal stent. Do you reopen the side branch? If you reopen the side branch, do you optimize proximal stent again? You perform kissing balloons in a provisional strategy? If so, do you repot? So these are your possible next steps. So maybe I'll open it up again to the group here and see if anybody has any strong favoring or what you guys are doing in your typical practice in this type of an instance.
Any cardiologist wants to answer, Timothy? ใช้ strategy ไหนคะ ลองคอมเมนต์ดูนะคะ
Dr. Timothy, you want to take the side branch as your first target, right? Also circumflex, and then you do the provisional circumflex to left main.
Yes.
And then you do side pot. And you consider now main branch, the LAD as a side branch. Okay.
Yeah. In this instance, we did. Yeah. Kind of almost the beginnings of an inverse culotte.
Yeah, as I mentioned earlier, I prefer to have a true 111 involving LAD, but this is only ostial circumflex. It's very, very difficult. Very, very difficult. It's most difficult to have a good flow to those two branch.
Agreed. Challenging the ostial circumflex lesions.
They always are.
Yeah.
I'm a fan of this dedicated bifurcation stent. There is another one. There is Polish stent. They call Paul Boss Limb. It is dedicated side branch. It had a larger middle cell area to take the carina, so you don't have any deform or any the complexity during the case. We call Paul Boss limb. Unfortunately, for Paul Boss limb is not approved by US FDA. It's only approved by CE mark. And it's a small company. Then they do not have logistic enough to spread the stent worldwide. the result of the Provisional 1, Provisional 2 is very fascinating.
So I will I'll proceed through our case further here. So employing a provisional strategy, stent, in this case, left circumflex in the left main. And then the first step is to reassess your side branch. And there's a number of ways that one can do that, evaluate the TIMI flow. There's a little bit of evidence or data to suggest that IFR of your side branch has some prognostic value, or you visually assess greater than 75% angiographic stenosis at that ostium. And highlighting the data, it's a reasonable strategy to do a proximal optimization technique and be done. That routine side branch ballooning actually may even have some associated harm with it, in part due to the deformation of the stent and at times disruption of the carina. And I'll show you that data in 1 second. And where you access the side branch can be critically important. And this is dependent in part on what your next steps are for your technique, whether you're going to employ a culotte or a T-stent, prefer for a distal crossing. That is by and large preferred, in part because of the preservation of the neocarina and this downward displacement of the stent from the true left main into the side branch, being preferable as compared to crossing in a proximal strut, and you get this upward displacement of the stent into the main branch. There's a lot of data and bench models looking at this, but really this is the reason that routine side branch dilation may not be preferable, because invariably there's this downward distortion and displacement of the stent within your main branch, regardless of where you wire your side branch. And so to some extent, you're placing your main vessel at risk, employing a routine side branch ballooning strategy. That's what the data suggests, is that when you pot and then routinely side branch balloon, the risk of repeat revascularization may even be increased as compared to a true provisional, or not routinely ballooning your side branch.
And I must admit, in this scenario, I will utilize a lot of intravascular imaging to understand how the plaque was displaced and what that carini looks like before using simply what appears to be angiographically severe, because those acute angles immediately post-stent create an appearance of a worsening lesion that actually may not be physiologically significant.
I will say that if one were to balloon your side branch, then you really ought to repot proximally. You'll see here the proportion of stents which are malopposed increases after you balloon your side branch, and that can be resolved with repeat optimization of the proximal stent. So I think if you are to employ that strategy, it's critical to go back to the proximal stent and re-balloon. And then routine kissing balloons really has not been shown to be effective in single stent strategies. These are, again, looking at bench-side anatomic collaboration or evaluation of stents. When you do a routine kissing balloon, the stents become very elliptical, increase your proportion of malopposed struts, and actually can decrease the volume within the bifurcation pentat, or the true core portion of your bifurcation lesion. So routine kissing balloons for provisional strategy is probably ill-advised. This is data from the DK Crush 2 trial, that in a single stent strategy, final kissing balloons does not have much as far as favorable outcomes, and it probably has a negative prognostic implications. And so then what do? You know, we've employed a provisional strategy, and I'll show you our example here in this case to conclude in a minute here. But once we've employed a provisional strategy, what are the best strategies should you have side branch loss, occlusion, reduction of TIMI flow greater than 75% osteostenosis? And at that point, your bailouts include a culotte, a tap, or a TM protrusion, or the three mechanisms that one could employ when you have encountered some difficulty at your side branch. And you know, there are some data, this is the BBK trial, where people were employing a provisional strategy, and when there was side branch loss or side branch stenosis, they were randomized to either a culotte versus a TM protrusion technique as a bailout bifurcation. And the data suggests that in this case it was a T and tap, that you know, you have a decreased stent volume within the side branch, and most of that comes from a stenosis that is identified at the side branch of the ostium with T and tap. So you don't have the same volumetric gains that you do with the culotte. So in this instance, you know, if the angle is favorable, a bailout culotte strategy is probably preferred. Again, this is not clinical outcomes, but this is a volumetric assessment of your stent sizing and stenosis. So I'll bring you back to our case now and try to kind of walk you through, you know, now that we have a bit more of a background understanding of maybe optimal strategies according to the current data. And so, you know, number one is that, again, we have this core valve to navigate. And so we had to use a JL guide, which was probably otherwise not favorable in this instance, because you're really limited to using short, less supportive guides. And you'll see we often have to use guideliners, which will also be the case here. We put a run-through coronary wire down the circumflex with plans to employ a provisional upfront strategy. In part, you know, we risk stratified the anatomic lesion, that we thought the LAD was certainly involved, but probably not greater than 70%. The angle seemed reasonably favorable, less than 10 millimeter lesion length. So we were hoping to employ a provisional strategy in this instance. You'll see now our relatively unsupportive guide is helped with the addition of a guideliner. In this instance, we took a 2.0 non-compliant ballooned the circumflex ostium into the left main and wired the LAD as a marker wire for protection. Balloon slightly distally in the proximal circumflex. And at this point, we had decided that we thought the ostial LAD, whether it was thrombus shift or plaque shift or possibly coronal shift, those three mechanisms, side branch loss, we thought that the ostial LAD appeared to be more involved than we had initially appreciated. So we did IVUS. I don't have that to show here, but at this instance, we decided that we were going to proceed with a two-stent strategy with the culotte technique. So we went back over our LAD wire. This is again a 2.5 NC balloon at this point, pre-dilated the lesion, which had full and symmetric expansion, albeit, you know, there was calcium in these vessels. And then we came back with a 3.0 stent within the left circumflex into the proximal, rather into the mid shaft left main. That was deployed. The culotte strategy, our LAD wire was removed, and a second wire was used to identify a distal strut through which we wired the LAD, ballooned with a 2.0 balloon. We are lining up our LAD stent, extending just proximal to the previously placed stent. Now we're kind of in the mid shaft left main, extending in the proximal LAD through that side branch where it was deployed. We come back with our simultaneous kissing balloons. So this was a 3.0 NC and a 2.5 millimeter NC. This was our kissing balloon. And then understanding that we had elliptical deformation of the left main stent, we come back and perform proximal optimization technique. This was with the 4.0 NC in the left main, sized according to our IVUS run. This is the completion angiography. So I have a culotte left main vessel being the circumflex, the LAD being the side branch. Pretty nice angiographic result. I also performed IVUS at the completion. Everything appeared to be fully expanded and opposed. I'll open it up. Anything that you in your practice would have done different, strategies you would have employed different from our own.
Yeah,
Anyone?
great case. The angiographic result is very good, except we cannot see your IVUS the finding on both branch, circumflex left main, LAD left main. That would tell a different story, but angiographically look very good. But I still feel that in 9 months or 12 months midterm follow-up, you may intervene with the ostial side branch narrowing. It's normally it's around 15%, 20% that we accept. There is going to be another treatment on side branch.
Yeah, I don't disagree. I would say I tend to, in vessels like this, do less culotte and more DK brush. Two of my colleagues tend to primarily do culotte unless the angulation is extreme.
If you look at angiogram in this view, you feel that the ostial circumflex is still not well expanded.
I think that the, by IVUS, the stent was well expanded in the lesion, but the lesion still didn't yield relative to the reference. So, the issue in these cases of plaque modification prior, I think, is always an issue. And I think it would have been nice to do some plaque modification before, and given the location, I think that this would have been a nice IVL while protecting the LAD wire over rotational atherectomy.
To my eyeball, the circumflex, if you look at a little bit more distal circumflex, the caliber is quite large, maybe larger than the LAD. It's surprising that normally LAD should be larger than circumflex.
It's a big cert, no doubt about it. But I think this case illustrates, the challenges of treating coronary disease following a core valve. And we'll share a couple of manuscripts that came out in JACC Intervention that are good basic reviews that I always find helpful. And then second, the emotion and passion over how to handle the left main, which I think, many people are quite passionate. And I think the most important thing is the angulation and how the coronae appears. So a fun case to go through.
Thank you. Anyone have a last comment before we finish at 9:15?
Hello, I'm Dr. Bunsom from Bangkok Hat Yai Hospital. It is a very excellent case, and I have some question about the technique. When we use the two stent technique and kissing balloon and pot, and sometimes has another technique, just add the hug balloon in the left main after kissing, and pull back a little bit to precise the left main and kissing again. It's called a hug technique. It's favor in Korea or Japan. I don't know about the concern about if I use hug technique, the left main or the vessel has the elliptical shape, but use pot, it had the circle shape, and in the music registry or music try is concerned about the circle of the left main or the elliptical shape of the left main. I don't have the knowledge about this strategy. What is the best or concern about the shape of the left main or about the hug technique and or pot technique for the left main, please?
Yeah, I think, we're certainly happy, and we may take 15 minutes next month and go over that, given the time of the evening here. But I think that's a great question that is worth spending some time chatting about.
Thank you. We take note
Thank
of
you.
that. So for next time, we will give you the first 15 minutes, Prof, as you kindly suggest.
Wonderful. Wonderful seeing everybody, and thank you for taking the time to go over the case with us. It was great engagement and great points that were discussed. So thank you for enriching it.
Thank you for the same, Prof. We learned a lot too. Thank you.
All
Great
right.
case. Great case. Thank you. Goodbye.
Thank you.
Bye.